Hi everyone. In this conference I will try to present the latest consensus and developments in primary care in neonatal brachial plexus palsy. The neonatal BPP refers to paralysis of the upper extremity secondary to a traction injury sustained to the brachial plexus during birth. Neonatal BPP varies in severity and the extent of plexus involvement, ranging from transient neuropraxia to complete cervical nerve root aversion of all of the brachial plexus. The aim of this study is to search from a review of the literature for the latest consensus and developments in the evidence of nerve repair, early predictors of microsurgical reconstruction, indications, surgical timing, and surgical management. Looking for evidence of nerve repair, in this paper published in 2014, a systematic review of the literature was performed to identify studies that compare nerve reconstruction to conservative treatment. 9 papers were identified that directly compare the two treatment modalities, but none of them alone can represent sufficient evidence for nerve repair because of selection bias or small number of cases. Pooling of data was not possible due to differences in patient selection for surgery and outcome measures. Although nerve repair in neonatal BPP has not been investigated in a randomized fashion compared with lateral recovery, it would be erroneous to conclude that there is no place for surgical treatment. The main justification of nerve surgery is formed by the poor outcome of spontaneous recovery in a certain percentage of patients. For infants with a total lesion without any functional recovery at 1 to 2 months, the prospect is poor. It is known that spontaneous recovery of useful hand function does not occur. Around 30% of infants with neonatal BPP do not show complete spontaneous recovery, which has a permanent impact on daily life. Autopsies and surgical exploration revealed totally ruptured nerves and nerves avulsed from the spinal cord. Such findings of complete discontinuity of the peripheral nerve exclude any spontaneous recovery in this particular nerve. From the included papers in this study, it may be concluded that recovery of the biceps before the 3rd month is a predictor of complete or near complete recovery of shoulder function. Additionally, with the increasing delay of initial recovery, the prospect of a good eventual outcome decreases. It is important to realize that starting recovery of the biceps is employed as an index for prognostication of the shoulder function and not per se a predictor for the recovery of the biceps muscle itself. Having a good shoulder function is very important. It allows to orient the arm and the hand in the useful space in front of the body and face. The exact cutoff point to perform nerve reconstruction cannot be determined, but it is probably somewhere between the 3rd and 6th month. Conservative treatment consists of waiting for spontaneous recovery and treating residual deficits. This strategy has 2 limitations. First, a functioning muscle must be available for transfer. If the initial nerve lesion consists of a flail arm, no functioning muscle is available to restore hand function. The second limitation is that performing nerve reconstruction after a failed muscle transfer is not possible. Moreover, it does not seem logical to leave a reparable nerve injury in place, wait for unlikely recovery, and treat the residual deficits later. To get an idea of the seriousness of the injuries and to plan a possible microsurgical reconstruction, a prospective multi-center cohort study of infants with neonatal BPP was performed to define the demographic, perinatal, and physical examination characteristics leading to microsurgical reconstruction. Among physical examination characteristics prior to 3 months of age, the only factors to demonstrate independent predictive value for microsurgical repair were Horner's syndrome as well as anti-gravity elbow flexion, wrist extension, and finger-thumb wrist flexion. In this series, with the addition of each additional factor from these 4 characteristics, an increase of about 20 to 30% in the rate of microsurgery was noted. For microsurgical repair, there is no universal consensus regarding the indications and the timing. However, there are some clear areas of consensus in the literature. Infants with a total palsy who show no signs of recovery definitely will require early surgery within the first 3 to 4 months of life. Similarly, consensus reigns that infants with a mild neuropraxic injury who demonstrate good recovery by 1 or 2 months are best treated conservatively. But in addition to those groups, infants are most often in a gray zone where decisions about surgery or no surgery are not black or white. Thus, for upper brachial plexus palsy, some surgeons have adopted Gilbert's attitude to operate at 3 months in the absence of anti-gravity elbow flexion. Others wait longer, and others take into consideration other predictors of poor recovery. In this paper published in 2022, the authors have systematically examined the existing literature and investigated the correlation between age at time of upper plexus microsurgery and surgical outcomes. The mean age of all included patients was 11.4 months, range 2.5 to 65 months. Microsurgeries performed in these studies include nerve grafts, nerve transfers, neurolysis, neuroraphy, or a combination of these microsurgical procedures. The conclusion of this review article is that in upper trunk palsy, there is no significant difference in the results of microsurgeries performed before or after 6 or 9 months of age when comparing elbow flexion, shoulder abduction, and shoulder external rotation. These findings can be explained by the fact that in some studies, nerve transfer techniques have been used which permitted to operate older children and improve their final recovery. For the surgical management, treatment of neonatal BPP differs greatly from that of adult BPP. Infants have a much greater potential for recovery, have shoulder limbs along which axons need to regenerate, and have greater brain plasticity. Hence, the priorities of brachial plexus reconstruction are different in children compared to adults. Hand function must be the primary goal. After hand function, the priorities in order are elbow flexion for hand-to-mouth function, shoulder stability and motion, and elbow extension to allow for overhead function and increased workable reach space. Nerve graft used to be the gold standard repair technique for these injuries. However, the success of nerve transfer techniques over the past 20 years has pulled this paradigm into question. Compared to nerve transfer, nerve graft provides a greater number of axons and produces an anatomically correct reconstruction including sensory reinnervation. But among the disadvantages of nerve graft repair is that axons must traverse a longer distance and 2 areas of coaptation prior to reaching the motor end plates and sensory targets. This inevitably leads to some degree of axonal loss, misdirection, disorganization, and co-contraction. Nerve transfers are attractive because they are technically easier and faster to perform than brachial plexus exploration and grafting. There is a single area of coaptation which is much closer to the target muscle, allowing for earlier reinnervation with less co-contraction. Distal nerve transfers do not require the excision of damaged but partially functioning nerve, thereby avoiding risks to intact or recovered function. The limitations of nerve transfer include the lack of sensory repair and the motor relearning necessary to maximize function. Therefore, nerve transfer has gained popularity in the treatment of adult brachial plexus palsy. However, their role in the treatment of neonatal BPP remained unclear until 2015. Senes suggested in 2015 that microsurgical repair is the technique of choice for affected children in their first year of life. The direct exploration of nerve trunks permits to be able to assess the level of nerve damage more correctly and to perform a more accurate nerve repair. He considers that neurotization procedure is a supplementary method to help the patients attain a better outcome, precisely in total palsy with lots of root avulsions or when primary nerve reconstruction is no longer possible, such as late presentation, isolated deficits, and failed primary reconstruction. It was the same conclusions of the International Federation of Societies for Surgery of the Hand Committee report, published in 2015 after a literature review. Furthermore, CNES confirmed that neurotization procedure is rarely feasible in children up to the age of 6 years or a little more, because in neonatal BPP a complete denervation of the muscles rarely occurs. In this paper, selective neurotization of certain muscles yielded considerable functional recovery for patients who had partial movement recovery during infancy. These are the 47 neurotization procedures performed in their selected 32 patients. For the suprascapular nerve reconstruction, the authors prefer to spare the accessory spinal nerve in primary brachial plexus repair with the intention of using it in a possible secondary nerve reconstruction for two reasons. The first is that in primary brachial plexus repair, suprascapular nerve reconstruction is achievable by means of grafting from C5 root or using accessory spinal nerve neurotization. And the comparison of the two methods does not show significant difference in the results. The second reason is that after primary nerve surgery, in a vast number of patients, shoulder stiffness precociously occurs, interfering with the functional outcome. For the elbow flexion, neurotization of the musculocutaneous nerve can be done by the Oberlin's procedure in case of upper trunk palsy and intercostal nerve transfer in total palsy. Several other publications recommend performing the modified Oberlin procedure, adding the transfer of median nerve fascicle to re-innervate the brachialis muscle. In order to optimize elbow flexion recovery, this is what you see at the top right. Elbow extension is important to stabilize the elbow without the contralateral hand and to gain a useful grasp. Thus, as with elbow flexion, in upper trunk palsy, the ulnar nerve fascicle is the number one choice, and when the lower plexus is affected, the intercostal nerve represents a good alternative. For the patients with paralysis of the serratus anterior muscle, the neurotization of the long thoracic nerve can be obtained by means of the lateral branch of thoracodorsal nerve or by one intercostal nerve. The aim is to treat the scapula winging and improve the shoulder abduction. Overall, there are numbers of methods to choose for the repair of upper trunk injuries, but there are fewer methods for the repair of lower trunk injuries, which mainly include intercostal nerve, phrenic nerve, or contralateral C7 nerve transfer to reconstruct finger flexion. In addition, the curative effect is poor, and fewer than 50% of cases can recover muscle power above M3. Since 1999, and for inferior root avulsions with intact C5, C6 plus or minus C7, several publications have concluded that transfer of the brachialis muscle branch for selective neurotization of finger flexion is anatomically safe and effective with satisfactory clinical results. This neurotization has been used in cases of adult BPP and after spinal cord injury. So far, no publications have been found regarding neonatal BPP. In conclusion, we will answer the questions posed at the beginning. Is microsurgery necessary? It is clear that it is a certainty to try to avoid the evolution to the unshakable hand in cases of total lesions and to optimize the recovery of shoulder muscles in case of upper or total palsies. Without a functioning group of shoulder muscles, patients have difficulty positioning the arm and the hand in the useful space in front of the body and face. The decision is based on predictive elements for a poor recovery such as Horner's syndrome, anti-gravity elbow flexion, and finger thumb wrist flexion. For the surgical timing, the exact cutoff point to perform nerve reconstruction cannot be determined, but it is probably somewhere between the 3rd and 6th month. For the surgical procedure, it seems that nerve graft is the technique of choice for affected children in their first year of life. The neurotization procedure is a supplementary method to help the patients attain a better outcome, precisely in total palsy with lots of root avulsions or when primary nerve reconstruction is no longer possible, such as late presentation, isolated deficits, and failed primary reconstruction. Thank you for your attention and for your patience.